Hello and welcome everyone. Today our topic of discussion is celiac disease. In this video we are going to discuss about causes of celiac disease, signs and symptoms of celiac disease, how to diagnose it and what is the treatment available and how to follow up after the treatment. Let's get the overview of celiac disease. Celiac disease is an enteropathy of small intestine. It is an autoimmune condition triggered by the gluten ingestion in genetically predisposed individuals. Gluten is a general term for alcohol soluble proteins that are present in various cereals including wheat, rye, barley, spelt, and kamut. The prevalence of celiac disease is higher in the first degree relatives and in other at risk groups such as patients with Down syndrome, type 1 diabetes, or IgA deficiency. This condition is chronic and currently only treatment consists of permanent exclusion of gluten from food intake. Celiac disease is a unique autoimmune disease and in that its key genetic element is expression of human leukocyte antigen HLA-DQ2 and HLA-DQ8. Second is autoantigen involved is tissue transglutaminase TTG, and third is environmental trigger, that is gluten. These all three are well defined. Besides genetic predisposition and exposure to gluten, the loss of intestinal barrier function, a pro-inflammatory innate immune response triggered by gluten, inappropriate adaptive immune response, and imbalanced gut microbiome all seem to be a key ingredient of celiac disease autoimmune recipe. Celiac disease has a strong hereditary component. CD is diagnosed more frequently in women with a female to male ratio ranging from 2 to 1 to 3 to 1. The disease can occur at any age from early childhood to elderly with two peaks of onset. One peak is shortly after weaning with gluten in first 2 years of life and the other peak of onset is in the second or third decade of life. Symptoms. Symptoms of celiac disease are headache, nausea, bloating, stomach pain, gastrointestinal distress, diarrhea, fatigue, weight loss. Now let's see the classification. The classification of celiac disease identified the following clinical presentation. There are 4 types. First is intestinal or extraintestinal, second is subclinical, third is potential, and fourth is refractory celiac disease. The intestinal form of celiac disease is more commonly detected in the pediatric population and the children younger than 3 years, and it is characterized by the diarrhea, loss of appetite, abdominal distension, and failure to thrive. The extraintestinal symptoms are common in both children and adults, and they include iron deficiency, microcytic anemia. The subclinical form include patients with the symptoms and signs below the clinical identification threshold and are often recognizable only after the appreciation of beneficial effects induced by gluten-free diet. The potential form of celiac disease is characterized by the positive serological and genetic markers with normal intestinal mucosa. It is called the potential form of celiac disease. And the fourth and final is refractory celiac disease. It is characterized by the persistent symptoms and atrophy of intestinal villi after at least 12 months of strict gluten-free diet. The refractory celiac disease can lead to complications such as ulcerative jejunoileitis, collagenous sprue, and intestinal lymphoma. This picture shows normal histology of small intestine showing villi and crypts. You can see villi are the elongated structures and crypts are at the base of villi. They are small and less in number. In the full-blown clinical picture of celiac disease, the typical feature of small intestine are the chronic inflammation and villus atrophy. You can say three main features of celiac disease is increase in intraepithelial lymphocyte, villus atrophy and crypt hyperplasia. A peptide derived from the gluten called gliadin causes damage to small intestine, and there is a local inflammation and the process leads to destruction of small intestinal villi. This destruction in turn leads to decreased functionality of intestinal surface and it leads to malabsorption. Now let's understand how to diagnose celiac disease. The gold standard for celiac disease diagnosis is represented by combination of two tests. First is duodenal biopsy and second is serological test. Duodenal biopsy consists of mucosal changes that we have described earlier, and serological test consists of autoantibodies like anti-TTG, anti-endomysium and diamidated gliadin peptide antibodies. Pediatric patients with high titer of anti-TTG antibodies, detectable anti-endomysial antibodies, HLA-DQ2, HLA-DQ8 positive, and other signs and symptoms are present, then it suggests celiac disease and you can skip the duodenal biopsy in such pediatric patients. The CD-related autoantibodies are belong to two classes, IgA and IgG, but only those of IgA class can be regarded as highly sensitive and specific for CD except for DGP antibodies. IgG, DGP are particularly useful in identifying CD in the early childhood. This picture shows step-by-step procedure to diagnose celiac disease. When you first suspect a patient with celiac disease on the basis of signs and symptoms, then you first advise IgA TTG antibody level and total serum IgA antibody level. Let's see the first case. In the first scenario, where IgA TTG level is positive but it is less than 2 into cutoff value with normal IgA level, then perform IgA antibody to anti-endomysial antibodies. If these IgA anti-endomysial antibodies are negative, then consider the other diagnosis. But if this IgA anti-endomysial antibody is positive, then go for duodenal biopsy. Let's see the second scenario, where the IgA TTG level is positive and it is higher than more than 2 into cutoff value with normal IgA level, then consider the duodenal biopsy. Now let's see the third scenario, where the IgA TTG antibodies are negative but total IgA is deficient. So go for IgG TTG antibodies or IgG DGP antibodies. If they are positive, then go for duodenal biopsy. If they are negative, then consider the other diagnosis. And if in the final scenario IgA TTG is negative and total IgA is also normal, then consider the other diagnosis, then celiac disease. Now let's learn about the duodenal biopsy. How to diagnose celiac disease on the basis of duodenal biopsy. Current recommendation to take biopsies are the 4 biopsy on the second duodenal portion and 2 biopsies from the duodenal bulb. There are main 2 classifications for this biopsy to diagnose celiac disease are Marsh classification modified by Oberhuber and second is Corazza and Villanacci classification. Now let's understand first Marsh classification modified by Oberhuber. It is divided into the 3 types, type 1, type 2 and type 3. Type 1 and type 2 lesion characterized by increase in the intraepithelial lymphocytes, which is more than 30 lymphocytes per 100 epithelial cells without or with crypt hyperplasia and normal villi. It is non-specific for CD, but together with positive antibody test and minimal intestinal lesions can indicate potential celiac disease. These minimal lesions are seen in the other causes like food allergies, Crohn's disease, lymphocytic colitis, bacterial and parasitic intestinal infections such as Giardia, common variable immunodeficiency, small intestinal bacterial overgrowth, non-steroidal anti-inflammatory drugs, and Helicobacter pylori infections. The normal intraepithelial cutoff has been established to be less than or equal to 25 lymphocytes per 100 epithelial cells, better identified with CD3 immunohistological stain. Type 3 is a typical lesion of celiac disease, shows villus atrophy with a change in a villi to crypt ratio less than 3 to 1:1 and increase in the intraepithelial lymphocyte. The type 3 is subdivided into the three stages where the partial, subtotal and total villus atrophy are seen, and they are 3A, 3B and 3C. The second classification is provided by the Corazza and Villanacci, and they divided into the two grades, grade A and grade B. Grade A is non-atrophic and grade B is atrophic, and grade B is subcategorized into B1, in which villi to crypt ratio is less than 3:1 but with identifiable villi, and grade B2 in which villi is entirely atrophic. So grade A lesions include type 1 and type 2 lesions based on the Marsh-Huber classification, and grade B1 lesions include 3A, 3B and grade B2 include 3C. Now let's learn diet and treatment for celiac disease. Currently, only effective treatment available for CD is strict gluten-free diet for the life, since it leads to resolution of intestinal and extraintestinal symptoms, negativity of autoantibodies and regrowth of intestinal villi. Studies are going on to check efficacy of enzyme supplement therapy with bacterial prolyl endopeptidases expressed by various microorganisms has been proposed to accelerate gluten digestion in the gastrointestinal tract and thus to destroy T cell epitopes. The third proposed treatment is modified grain can be developed either through selective breeding of early wheat species or using a small interfering RNA technology to mutate or silence immunostimulatory sequence. The fourth proposed therapy is a Gliadin is known to cause increased secretion of zonulin, which alters the intestinal permeability and facilitates the transport of gluten and triggers an inflammatory process. So, inhibitor to this, which is called zonulin inhibitor, larazotide, can block the gluten entry across the intestinal epithelial cells, and this drug inhibits the human protein zonulin, which regulates the intestinal permeability. Now let's learn about the follow-up. The strict compliance with gluten-free diet leads to disappearance of significant decrease in autoantibodies within 12 months and together with regrowth of intestinal villi. IgA anti-TTG antibodies are used to monitor follow-up. Patients should undergo consultation with dietitian and follow-up blood test including CBC, anti-TTG IgA, thyroid stimulating hormone, anti-thyroperoxidase, anti-thyroglobulin, ferritin, folate, vitamin D3, transaminases, a metabolic profile, and ANA antibody screening to rule out other immunological disorder. A second duodenal biopsy after gluten-free diet should be recommended only those patients with persisting symptoms and demonstrable laboratory deficiencies of micronutrients. So this is in short about celiac disease, and these are the references for this video. Hope you like it. Thank you and see you in the next video. Bye.